For today's video, we're looking at part 3 of our PAVM or manual therapy technique assessment for the cervical spine. And for this, we want to talk about several takeaways or key points associated with manual therapy techniques. If you haven't first watched part 1 and part 2, where we discuss CPA and UPA assessment, as well as the craniovertebral region PAVM assessment, take a moment and find those videos. So several key points that we should point out when we're working through the cervical spine. Number one, pain during segmental testing is a strong correlate or association with the report of neck pain. If an individual has left-sided neck pain or right-sided neck pain, and we go and we begin a segmental approach, oftentimes we can gain some degree of specificity to the segment that is giving them most of their discomfort and or pain, or multiple segments. However, even though there is a strong correlation and association with the report of neck pain, inter-tester reliability for segmental and joint mobility assessment is poor to mildly good. Rather, intra-tester reliability is significantly higher, and that is somewhat dependent upon the study that you are looking at for those reliability measurements. However, the assessment of pain for inter-tester reliability is better than the actual mobility assessment for both the cervical spine as well as when we get to the thoracic spine. So while mobility assessment maybe has a few limitations, pain is significantly better. So then the question becomes, well then why do we perform these techniques? Well, with manual therapy techniques, they're skilled movements that really are intended to do a couple things. One, they can modulate tissue extensibility. When we're working through the cervical spine, specifically after an acute macrotraumatic event, there can be hypertonicity or guarding of muscles. And one of the things that manual therapy can do is to begin to improve a bit of tissue extensibility. Additionally, it can help to increase range of motion by inducing relaxation. Now, that is somewhat patient dependent and has to be assessed on an individual patient-by-patient basis. So then there are really three things that can coincide with this segmental PAVM assessment, and those three things are as follows. First, when we're assessing a central PA, we can make an assessment of whether or not the movement we are feeling from one segment to the next is normal, if it is hypo, or it is hyper. That's about as good as we get. And so with hypo, we really see that as too little movement. Hyper is too much or might run the risk of cervical instability. And so when we're applying a graded mobilization, we really stick then to our Maitland mobilization grades of 1 through 4, with 5 being a manipulation. Now there are some that advocate for 7 to 13 grades depending upon your training, and that's really quite challenging, if not impossible, to apply to the cervical spine when we're talking about such a small amount of movement. The second thing that can occur is the modulation of pain or the reproduction of pain. Oftentimes when performed in an assessment, we're looking to either induce or bring about the comparable or concordant sign, and so in that case, we're actually looking to reproduce the pain at the segment and then identify is it craniovertebral, mid-cervical, or lower cervical in origin, such that we can treat accordingly. However, once the assessment is complete, the very same techniques that we are using from an assessment standpoint in terms of unilateral and central PAs can also become an interventional approach or treatment approach. And so we can begin to modulate pain by restoring healthy joint nutrition. Each time we do a unilateral PA, we are gliding those facet joints on each other, helping to nourish the articular cartilage. That's an individual joint space with innervation, and so it helps to restore not only normal joint mechanics, but can also help to eliminate or reduce the amount of inflammation and sensitivity at the joint. Finally, our last piece speaks to that, and that is restoring healthy joint mobility and kinematics. When working through central PA, as well as unilateral PA, in a segmental fashion, we ensure that we are looking at the entire cervical spine from lower mid even to craniovertebral and helping to bring about normal mobility and normal nutrition at each joint interface. So, while there certainly are limitations to manual therapy and there is debate regarding the efficacy of these techniques, certainly there are areas that we can agree are beneficial for our patient. Overarching all of this and really underpinning at the core of what manual therapy is doing is finally a concept known as a strong neurophysiologic effect. Now, the neurophysiologic effect has been discussed most recently in a paper by Belowski and colleagues in 2018 in the Journal of Orthopedic and Sports Physical Therapy. I would encourage you to identify and find that article. I will link it in the video notes as well. However, it would be really almost to the point of malpractice for us not to discuss the fact that whenever we are laying our hands on our patients, one, there is a strong psychological, psychosocial component to placing our hands on the patient, but two, really even more important, there's a strong neurophysiologic model that involves the autonomic nervous system, both our parasympathetic and potentially sympathetic nervous systems, and other pathways that help to modulate pain, improve mobility, and decrease the threat or the sensitivity to the overall nervous system. So, hopefully this review of manual therapy techniques and key takeaways or key points has been helpful as you review PAVM assessment for the cervical spine.